Dr. Linda, we are live.
So, good evening, everyone. Today, I welcome you all to this panel discussion on understanding constipation care across specialty and role of BixiBat. So, we Dr. Reddy's started in 1984 with a modest investment and bold vision. Today, with research and development center, manufacturing facilities, commercial presence across the globe, we serve over a half a billion worldwide, and we aspire to reach and touch over 1.5 billion patients by 2030. So, I am Dr. Linda, the Regional Medical Advisor from Dr. Reddy's. I request Mr. Alpesh to say a few words. Alpesh, are you there?
So, yeah, hi. Good evening, doctors. I welcome you all for this today's cross-panel discussion, and especially would like to thank you, Dr. Sundeep Laktakia, sir, for I think being chairing and moderating the session, and thank you very much for Dr. Anirudh, sir, for being the speaker of the program, and Dr. Nayantara, Dr. Bhishma, and Dr. Sujit for being the panelist. So, over to you, Dr. Linda.
Thank you, Alpesh. So today the scope of the meeting is to understand the real-world use of BixiBat in chronic constipation, to understand the critical elements for achieving the optimal clinical outcome, to understand if there is any new safety concern when we are using BixiBat, and also to gain insight on long-term use of BixiBat in treatment of constipation. So coming to the agenda, so there will be a welcoming address by me, followed by introduction and context setting by Dr. Sandeep Lektakia, and constipation, its management, unmet need, introduction of BixiBat, and a real-world case presentation by our speaker, that is Dr. Anirudh, followed by a panel discussion and a concluding remark by Dr. Sandeep. So today we are having an eminent chairperson, that is Dr. Sandeep Lekdakia, who is the Director of Endoscopy and US in AIG Hospital, Hyderabad. He is the President of Society of Gastrointestinal and Endoscopy of India. He was the Vice Chairman of International Committee of American Society of Gastrointestinal and Steering Committee member. And he has published more than 170 articles, both international and national journals, and he is the co-author of several current guidelines for pancreatobiliary and endoscopy care in all over the world. And he has invited as a peer reviewer for most of the indexed national and international journal, and also invited as faculty for various international and national endoscopy conference. I welcome you, sir, to this panel discussion.
Thank you.
And today we are having our eminent speaker, Dr. Anirudh Pratap Singh, who is a senior consultant, medical gastroenterologist at AIG Hospital, Hyderabad, who has completed his MBBS from Maharashtra University and DM gastroenterology from Kerala University of Health Sciences. He has participated in various research work and workshop under the gastroenterology department, published several articles in international and national journal, and also invited as a speaker for various international and national conferences on gastroenterology. I welcome you, sir, to this panel discussion. And we are having an esteemed list of panelists. We are having Dr. Bhishma Chowdhury, who is a consultant cardiologist in AIG Hospital. Dr. Sujit Reddy, who is a consultant nephrologist in AIG Hospital, and Dr. Nayana Tara, who is a consultant endocrinologist in AIG Hospital. I welcome you all to this panel discussion. So now I request Dr. Sandeep Lekdakia to give a brief introduction for this panel discussion. Over you to sir.
Thank you, Linda, for introducing the panelists and the speaker and myself. I know this is a little different, today's meeting. Normally, we have an internal meetings of the same specialty. This is a crosstalk between several specialties. We have cardiologists, nephrologists, neurologists, along with gastroenterologists. And the topic is constipation, which is little, I don't think any of you guys have attended any meeting where constipation is a predominant theme of the meeting. Also, the drug that we're discussing is BixiBat, which is a bile acid transporter inhibitor. Have you heard this name? Just curious to know. Sujit? Bhishma?
Regarding in relation to mechanism of action, sir?
No,
or,
in general, are you aware of it? Because it's a recent molecule for us. It's been there for only
last few months we got to
yeah.
know.
So are you using in your practice by any chance in cardiac?
In nephrology we have recently started, sir.
Okay, Sujit, that's interesting. Nayantara, what about you?
No, sir, I hadn't heard about the drug till I was introduced to it through this meeting. Yeah.
Good, that's an honest reply, and that's what I was looking for. Bhishma, what about you?
Yeah, I just came to know about recently, so a month back, but I've not initiated the drug as of now. But I'm considering the cardiac effects of this drug. After reading so many articles on this now, there are few cardiac effects too. I think we should start for cardiac patients too.
There's no force based on this meeting to start, but if you feel that it's looking like safe, then you may consider in your clinical practice. So we have Anirudh as an expert who has done some work on this, and he has more experience than most of us gastroenterologists at the national level also. And may I request Anirudh to kind of start your lecture and giving the background of what's BixiBat. It's a very peculiar name. You don't have, it's like a cricket bat, hello BixiBat.
Thank you, sir, for your kind words and introduction. Thank you, Linda, for having us on the podium. So I'm going to start my PPT. I'll just share my screen if you allow me to.
Once your screen comes, we'll mute ourselves so that we can just listen to you and there's no disturbance. We can see your screen. Yeah, please continue.
You can see my screen, sir?
Yes, I can.
Okay. So thank you. So we are going to discuss this, a very important symposium, since like Dr. Sandeep said, it's a very uncommon thing to have constipation as a main source of discussion among cross panels and various specialties. It is although very important whenever we have new molecule, especially constipation, which is a common problem seen by all of us. But still, you cannot refer every constipation patient, and also there is no need to refer constipation patients to gastroenterologists per se if they are responding to medications what you have prescribed. So you need to be aware of what all options we have in the market currently, as well as the new molecules concerning safety as well. So this is a very common thing when we have a new molecule, especially from Western Asia, Eastern Asia, that we don't know about that, and the safety profile is relatively shorter as compared to other molecules. We need to know in deep about them. So how to navigate current treatment landscape? So we have something called as bulking agents, which consist of soluble and insoluble fibers, and the mechanism of action of osmotic as well as bulking agents is actually luminal water binding, which increases stool volume, and it also softens stool, and it increases the bulk and causes patients to have HPACs, that is propulsive contractions, but it may also cause bloating, abdominal pain, distension, diarrhea, electrolyte disorders, particularly in patients who have compromised state of volume expansion, like coronary artery disease patients, ischemic heart disease patients, patients with nephropathy, CKD, and also sometimes uncontrolled diabetes mellitus. So you can give this safely in other patients, but in patients who have serious comorbidities, you may have to consider or at least titrate the dose appropriately. Fibers are very important, but the problem is that our Indian patients are already replete with fiber. They are taking around 8 to 10 gram per day. So you have very narrow margin of increasing the dose of fibers, which will cause more bloating if you increase them to a very high dose. There are another thing called as secretagogues, such as lubiprostone, which increases intestinal fluid secretion and softens stool, but it can also cause nausea, severe abdominal cramping, vomiting, and diarrhea. Concerning prokinetics, prucalopride is a very good option. It has selective action on 5-HT receptors, but it is a pan-GI molecule, like it will increase motility right from the esophagus to the stomach to small intestine and large intestine. So it also triggers other symptoms which may not be actually monitored or treated by prucalopride for treatment of constipation. It can also cause diarrhea, headache, severe headache, nausea, abdominal pain, and also some patients will have suicidal tendencies. So lactulose is the only osmotic agent which is studied in pregnancy. It is very safe, locally acting, proven safety for long-term usage, but the problem remains that a lot of patients get tolerant to this lactulose and may have bloating in long term. So it stops working after a while. You must have noticed in your clinical practice as well. Regarding PEG, it improves stool frequency and consistency. Effects may last up to 6 to 8 months. It is exceedingly safe molecule, but it is very mild. So in patients who have failed multiple therapies, this may not work. Again, it causes distension, diarrhea, and disturbances. And concerning magnesium compounds, which is commonly available over the counter, these are stimulant drugs. They are effective, low cost, and natural. But in patients who have uncontrolled diabetes or patients with CKD who have limited EGFR, may have hypermagnesemia, may have diarrhea, hyperphosphatemia, and it has to be cautiously used in elderly. It is unfortunate that these compounds have been there for a very long time, but it is still the safety and the efficacy data is not available for long term. So it has to be cautiously used in elderly, congestive heart failure, and renal insufficiency patients. So regarding sodium picosulfate, it is used for acute constipation and often used as a rescue therapy for patients with severe constipation. It exhibits an anti-absorptive, secretory, and prokinetic effect, but it is not recommended for use beyond a month, and the long-term safety data doesn't exist. In prucalopride, it is effective, but it has got some effect on the QT interval. When prucalopride was introduced, a lot of problems and discussions happened around cardiology, and a lot of people advise that in elderly patients, especially in history of arrhythmias, you should avoid giving 2 mg at night time. But subsequently, a lot of trials have now established its safety that it can be used up to 18 months to 24 months with potential abdominal pain benefits, even in patients with severe CAD. But I'm still not very comfortable prescribing prucalopride in patients who have severe arrhythmias or uncontrolled congestive heart failure, or patients who are on polypharmacies, because it is metabolized via CYP3A4 mechanism and can potentially cause drug interactions. So the drawbacks are depression. Sometimes suicidal thoughts have been described in this particular drug, and it has to be used cautiously in CKD patients. It is present in breast milk. Systemic absorption is there more than 90%, and 65% of it is excreted in the urine. So there are unmet needs with current treatment options. So half of them have efficacy, but they will develop tolerance after some time, and most of them have single mechanism of action. Long-term safety and adverse events, most of these drugs are available commonly for very long-term. We use it very commonly, but long-term safety data is scarce. If you go through milk of magnesia safety data, you will not find much literature on that. And some of them patients who are having multiple depressive episodes and polypharmacy, you will always be reluctant to use such drugs which have so much of systemic absorption with comorbidity patients. And also long-term laxative use may cause tolerance and dependency, which is very common with laxatives like lactulose. Milk of magnesia compounds do not have tolerance, but they cause severe abdominal pain and diarrhea symptoms. And the complex and frequent dosing of laxatives can also hinder patient compliance. So BixiBat in that way, a breakthrough partial IBAT inhibitor with dual action of inducing colonic motility and fluid secretion. It came to Japan in 2018. It was developed by AstraZeneca and then later transferred to Alvario AB with its development. And it's a novel first-in-class partial IBAT inhibitor with trials showing efficacy in managing chronic constipation. It was initially tested for refractory itching because it was a bile acid inhibitor, but later on they found out that at lower doses, it was causing diarrhea, so might as well as used for constipation patients. It acts locally in the lumen of the GIT, exerting a dual mechanism of action. It improves colonic motility, enhances fluid secretion, and also increases desire to defecate. So starting dose is around 10 mg once daily. Before meal, we'll have more discussion about that for 1 week, and then titrate based on the patient requirement. You have to up titrate if they are having constipation, you have to down titrate if they are having diarrhea. So it improves colonic motility. So actually most of the bile acid is absorbed through the terminal ileum. So IBAT is inhibited by the BixiBat, and this reduces bile acid reabsorption into the bloodstream. So the enterohepatic circulation of bile acids is interrupted, and whenever you ingest this molecule, it binds with the bile acids and it improves bile acid in the colon, and which will absorb more water. It improves colonic motility and colonic secretion, and it will also improve HPACs, which are responsible for enhancing the bowel movement in us. So it thus improving constipation. So this was a study which demonstrated in patients up to 24 weeks, that is a 4.5-year follow-up, and this was a single center observation study in patients who had hemodialysis, and also chronic constipation. So 54 was the total number of patients which they studied. The profile constituted diabetic nephropathy, chronic glomerulonephritis in majority of the patients. Mean age was almost 70 years. Some other etiologies were polycystic kidney disease, chronic pyelonephritis, patients undergoing hemodialysis. And you can see here, ilobexibat significantly increased the frequency of spontaneous bowel movements. And also, this is a commonly used Bristol form stool scale in our patients, where we measure that how is the patient responding to the treatment. It also improved in these patients at last observation. So this is all okay, but how about causing electrolyte disturbances in such subset of critical patients who are undergoing hemodialysis? So you can see that it demonstrated no significant change in serum potassium levels and also chloride levels and albumin levels up to 4.5 years of continuous usage. The mean change in LDL cholesterol showed a significant statistically decrease over the analysis period, and all adverse events were mild, like abdominal pain. Diarrhea is obviously expected, but it was mild and managed with temporary discontinuation of the therapy and also nausea in few patients. So ilobexibat performed placebo in enhancing bowel movements in Indian patients as well. So this was a prospective multi-center randomized double-blind parallel group placebo-controlled trial. It was a phase 3 superiority study wherein ilobexibat was compared with the placebo. You can see here it increased weekly spontaneous bowel movements frequency more than placebo and also complete spontaneous bowel movements with ilobexibat more than the placebo. So it is obviously expected that it will work better than placebo, but however, these are the requirements of DGCI and FDA. You have to always compare the efficacy with the placebo to get the approval done. So this also had spontaneous bowel movements within 24 hours with ilobexibat than with placebo, and it had shortened median time to first spontaneous bowel movements than the placebo in 11 hours. So it was well tolerated in our population, and out of 150 patients who were included, 15.3% patients reported at least one adverse events, which were dry mouth, abdominal distension, mild abdominal pain, and diarrhea. Diarrhea is 1.32%. So diarrhea is obviously expected when you are treating a constipation patients. However, the incidence should not be very high and it should be improving with temporary discontinuation of any therapy, which is there seen with ilobexibat. So it was well tolerated with no significant safety concerns over 2 weeks of once daily treatment, which is very short-term follow-up. However, this was for approval. We are doing also considering long-term studies and safety data of ilobexibat over a long period of time in Indian patients. This is another study which showed ilobexibat was safe and effective in elderly patients. You can see patients with 65 years, 75 years, there were increase in spontaneous bowel movements, and also Bristol stool form scale also improved in these patients, and it appeared to be well tolerated in elderly patients with chronic constipation, with only 4.4% of the patients more than 65 years of age and 3.5% patients more than 75% of age reporting some sort of adverse events like diarrhea, abdominal pain, and nausea. This was another study, could be useful to Dr. Bhishma. Ilobexibat in CAD and heart failure patients. This is a very small study which took 18 patients with chronic constipation. Frequency of spontaneous bowel movements increased by 2 per week. However, both the degree of straining during defecation and low density lipoprotein levels significantly decreased. So a lot of the problems come with when the patient starts to strain. If they have to strain at constipation, it can cause ischemia and also trigger heart failure and also sometimes precipitate myocardial infarction in these patients. So it is very important to decrease straining, and also LDL cholesterol as a corollary marker. If any drug can decrease LDL levels, it is a win-win situation for any patient who has concomitant CAD and dyslipidemia. Although not significant, the difference in BP before and after defecation tend to decrease from baseline by approximately 10 millimeters of mercury at week 12. Serious adverse events were not observed in any of these patients. However, long-term data with a larger number of patients are required definitely, especially in our population. A multi-center post-marketing surveillance was conducted in over 3,000 elderly patients who also had some sort of cardiac comorbidities, some sort of renal abnormalities, diabetes, and many comorbidities in these patients. This is a Japanese cohort, and as you can see, a lot of patients improved, but also had diarrhea, pain in abdomen, which ranged from 3.1 to 4% somewhere, and no serious adverse events were observed in these patients. So time course of defecation frequency per week in 4-week treatment period and 52-week treatment significantly improved. You can see here, and it also caused very minimal adverse events. So if you have to summarize all these things, it appears to be safe in patients with comorbidities. The only red flag what they had raised is a Parkinson's disease. However, there's a large data which has to be updated now, that there was incidence of adverse events, but these patients actually have a on or off phenomenon based on the multiple drug treatment what they are taking. So the diarrhea incidence was relatively higher in Parkinson's disease patients. But if you look at other cohorts like heart failure, cancer, renal disease, and diabetes mellitus, the incidence of diarrhea was low, and the incidence of adverse event were also ranging from 3 to 4%. Majority of them were diarrhea. In heart failure patients, the incidence of adverse events were 17%. If you can see here, BP differences before and after defecation decreased by 10, systolic blood pressure and diastolic blood pressure at week 12. The clinical significance was not very important and also did not reach statistical significance in the analysis. And the spontaneous bowel movement frequency increased, ranging from 2 to 4.3 per week, and the Westall Forms 2 scale also improved, and the degree of straining significantly decreased in heart failure patients, which is very important considering the risk of precipitation of heart failure in this subset of patients. So this is a clinical case, 74-year-old elderly male with significant comorbidities with diabetes mellitus, hypertension, on calcium channel blockers, nitrates, receiving nicorandil aspirin, dyslipidemia, chronic kidney disease. He was taking phosphate binders but was not on hemodialysis, and chronic obstructive pulmonary disease. This is a very common subset of patients which we see and we manage together in our hospital at a tertiary care center. So this patient had a severe constipation. He was not having any urge. He was straining a lot. He was having poor stool consistency, which was impacting his comfort in daily life. As usual, colonoscopy was normal. Manometry was showing some sort of dyssynergia, which we always treat. Like if there is dyssynergic defecation, that is a loss of synergia between the muscles of these patients, which may impact defecation. We correct that with biofeedback therapy, with anatomical manometry, and then we try to titrate the drugs as per the requirement. So this was a chronic functional constipation with dyssynergia, likely secondary to polypharmacy, systemic disease, and gut motility dysfunction related to diabetic autonomic neuropathy and CKD. So stool transit was not performed in this case. So we started with lactulose syrup, 30 ml at bedtime with no meaningful relief. Bulb forming laxative causes worsened bloating of these patients. We also tried prucalopride, which caused a severe headache in this patient, so we had to stop. Then we stepped up to stimulant laxatives. There was temporary response for 2 months, but then patient developed the tolerance. So there was persistent incomplete evacuation, straining, and loss of defecation urge. And the patient was losing all confidence because multiple treatment have been tried, and also patient was on polypharmacy. So BixiBat was initiated in this patient, 10 milligram OD before breakfast. Sometimes based on the patient response, we may also give it before lunch, but the only catch is that since it works with bile acid binding, patient needs to have a good meal before a major meal, and then sometimes some patients skip breakfast actually. So that time we can give before lunch also to have a good bowel movement. And within few days, patient reported spontaneous improved bowel movements, restored urge to defecate, and reduction in the laxative use which he was using for rescue, and enhanced daily functioning and comfort. So if you look at the other parameters with laxative of BixiBat, it improves glucose and lipid metabolism. So other drugs which we are using currently, none of them has any side effect or improved metabolism, except for their inducing the diarrhea. So this was a single-arm pilot study which evaluated the metabolic effect of BixiBat for 12 weeks in 21 patients with type 2 related constipation. So HbA1c improved from 7.8 to 7.6%, and LDL cholesterol levels also improved from 120 to 98.5. So along with constipation, it also additionally improves glucose and lipid metabolism in patients with diabetes mellitus. The problem is that if you ask me that whether I should treat it as a primary thing in patients who are pre-diabetic with constipation or pre-diabetic with some dyslipidemia, I will not say yes, because this is just an adjunct mechanism. So you have to primarily treat the patient, but you can reassure them that this drug will also improve your glucose and lipid metabolism, although partially may not have clinically significant effect, but at least it doesn't worsen this condition, and it is an additional advantage of using in diabetic patients. So it is locally acting and eliminated through feces with 0% absorption. So it is minimally excreted. As you can see here, lactulose 3% absorption, renal elimination, milk of magnesia 15% renal elimination, sodium picosulfate 10% renal elimination, prucalopride is 65% renal elimination. So it is very difficult to use in patients who are already on polypharmacy, especially with low eGFR. And BixiBat has got 0.01% renal elimination. So basically, it is very useful and also safe and reassuring to the patients with CKD, with decreased GFR, or diabetes patients with multiple comorbidities and decreased GFR, that they will be able to tolerate this drug with minimal adverse events. So this is another corollary marker which we can study, as in how many patients you need to treat to prevent one bad outcome such as constipation. So the relative number to treat, this is a statistical modality to study which drug is effective, because there are not many head-to-head trials among these agents. So BixiBat, the number needed to treat is 3 as compared to 4 and 6 in other laxatives. So what is the ideal time for BixiBat administration? This is a very difficult question to answer. So this was a study which tried to look at that age more than 20-year or older, functional constipation by Rome 4 criteria, which is a standard criteria to define constipation in gastroenterology for 1 year. And then the study actually administered the drug pre-dinner, because this is a convenient time to take most of the laxatives, and improved Bristol form scale from 1, 2, and 4, 8 weeks after treatment. Also improved spontaneous bowel movements. The mean onset time until spontaneous defecation also improved to 4 to 5 hours. That means early in the morning, which was earlier than by conventional constipation treatment drugs. And it almost remained constant during the entire course of the treatment with no tolerance development at all. And spontaneous defecation was achieved by almost 3/4 of the patients within 24 hours and 90% of the patients within 48 hours. And BixiBat also improved patients' quality of life in these patients. This is a Japanese study in more than 3,000 patients. So pre-dinner administration of BixiBat improved constipation, pain, and bloating, and also quality of life by management of fixed defecation. So this is a summary slide. Lactulose is locally acting. BixiBat is also locally acting. If you see electrolyte disorders, which is most commonly caused by lactulose, milk of magnesia compounds, PEG, and sodium picosulfate, BixiBat has no effect on electrolytes. Safety in elderly is very much established in BixiBat. It is not quite well established in other drugs. In diabetic patients, the other molecules have not been studied properly. However, lactulose sometimes may trigger abnormalities in blood glucose. It is very sweet in taste. So sometimes patients are aversive to taking lactulose, although the glucose concentrations do not change significantly, but still a lot of patients with diabetes will inquire about this molecule because it is exceedingly sweet. BixiBat, in that regard, improves diabetic profile of these patients and also improves LDL cholesterol. Regarding cardiac safety, the data needs to be accumulated. Although in a large cohort of 3,000 patients, cardiac safety was well established. However, we need to validate in our own population as well. But so far, so good. No side effects have been observed concerning the cardiac profile of these patients. Renal safety has also been established with BixiBat. However, with other drugs, there are concerns which have been raised, like hypermagnesemia, hyperphosphatemia, and also some electrolyte disturbances because of rapid fluid shifts. Regarding abdominal pain, this is a commonly noted adverse events among stimulant compounds. However, it is not very well seen with lactulose, but BixiBat also has got some abdominal pain. Bloating is not well seen with BixiBat, and suicidal ideation is only described with prucalopride, although it is not very commonly seen clinically. But cardiac safety wise, prucalopride can still be used based on recent randomized control trials, but I will be very careful in using 2 mg. In patients who have recent history of arrhythmia, I'll be comfortable with using 1 mg. So again, this is a summary of the same slide. I would like you to highlight that prucalopride has got interactions with the multiple antibiotics which have been used, and efficacy is diminishing as we move forward towards 12 or 14 weeks. And the long-term safety, if you see, lactulose is for 6 months, which is available. PEG up to 6 months, it is available. Sodium picosulfate, the safety data doesn't exist beyond a month. And prucalopride, the safety data exists for 1.5 years. However, BixiBat long-term safety data is available for 4.5 years. There is an inhibitory effect on P-glycoprotein. So sometimes when you are giving antiretroviral therapy, you may need to be careful in these patients. And also, it will increase motility, increase fluid secretion, defecation desire also. There is a concern raised by some people that the bile acid pool may decrease, but there is no clinically significant adverse event based on that. So take home message, one size doesn't fit all. You have to individualize treatment based on the patient's comorbidity. You have to put it into a profile. Do not just use one drug for one patient. Start simple, begin with fiber in Indian patients. However, you will not be able to optimize it properly because all of our patients are actually taking quite good amount of fiber in their diet. Step up rather than top down. So you start with low dose, then take it to higher dose, reassess and refine, monitor response, and adjust always as needed as per the patient requirement. You have to address reversible factors like some of the medications you can take it out. You have to improve the diet, hydration, lifestyle. Think beyond the gut, consider some comorbidities. Also take out some antidepressant drugs which can actually trigger constipation if it is possible after discussing with psychiatrists. BixiBat is a novel option. It is a selective IBAT inhibitor offering a new dimension in the current landscape of constipation treatment, and tailored therapy will be the future. So who wins, laxatives or BixiBat? So it is the patient who should win always in the clinical scenario. They are the most important, who we have to take care always, not one molecule. And what is our ultimate mission? So ultimate mission is to look at the data, look at the science, whatever is good. And always we should remember that science must win regardless of the type of molecule, what we consider in treating these patients. So thank you so much for your attention. I end my talk here.
Thank you, Anirudh. That was very nice. I'm sure all of you must have got some knowledge about BixiBat. Any questions or comments from the panelists? So Anirudh, you suggest that this medicine to be taken in the night after dinner. Start with 10 mg and then taper down to 5, or start with 5 mg and then increase up to maximum dose of 10 mg?
Sir, we should start with 10 mg, and the current data, whatever is there available in Japanese literature, they have been giving it before breakfast because naturally bile acid pool will be maximum before they have taken the first meal. But in our patients, I've been noticing that some of them take very light breakfast. I don't know, some of the elderly patients skip breakfast, and a lot of errant, like timings are different. The quality of food is different. So sometimes they might be able to take before lunch as well. I've been trying this before lunch, before dinner, as well as before breakfast. And all patients are different. So nowadays I have started asking them that take it before breakfast, maintain a diary, and just notice your stool bowel, the movement timings when you are passing your stool. And based on that, we can actually titrate your dosage. So suppose if they're having first, even suppose if there are retired people, elderly people who are staying at home, or housewives, we can give before lunch. So if they have an unpredictable bowel movement, at least they can do that. In office going people, we should give before dinner. That is better.
Okay, thank you. So whichever is the major meal, I think it has to be before that so that bile acid can be absorbed. But where would we place this medicine because of in patients who have comorbid, as you showed in the first case, who has cardiac problem, nephro problem, neuro problem, endocrinology problem, and there must be, I'm sure, several drug-drug interactions. Is it well known, or which are the drugs we have to be extra careful apart from what you told about the ketoconazole and macrolides?
So, sir, for procalyoprid exists, BixiBat has no drug-drug interaction because it is not metabolized by any enzyme. It has got 0.01% elimination through renal route and also 0% systemic absorption. So it is a bile acid inhibitor. So only drugs which are metabolized only through bile mechanism, probably that may be affected, but it has got no significant drug interaction so far.
Okay.
Exceedingly safe otherwise, based on the pharmacokinetic properties.
Okay, so let me throw the questions or comments from the panelists now. Bhishma, we saw that there is some literature evidence to suggest that LDL comes down with BixiBat. Also, the blood pressure can come down. So would you now be considering, or in patients who have lipids being higher or mildly high, you can bring them down with, and they also have constipation, would you use this as an add-on therapy to relieve, to hit two birds with one stone? Or you will actually go with a more conventional type of medicines and dietary restrictions of lipids?
I would not add this as a first line option just for the LDL purpose itself. Probably I would add it as an added extra value apart from the constipation which it fixes. So if you see, constipation is just purely not a GI issue. So we have lost patients who strained in bathrooms and awaiting procedures, awaiting procedure next day. They collapsed in the washrooms. So we did have some patients in our own hospital. So I think it's just purely not an GI issue. It does trigger few vulnerable patients, and like we all know, it increases intracranial and interthoracic pressures and causing transient hypertensions and vagal stimulations and fluid shifts, and which does affect our vulnerable patients. So like I just told you, and if it adds value for LDL also, and it prevents constipation and it doesn't affect our vulnerable patients, we are more than happy. And from what I've read, it doesn't affect the cytochrome system. So most of the cardiac drugs act with the cytochrome P450 system. So all the antiplatelets, anticoagulations, and digoxin, all that are metabolized through that cytochrome system. So it doesn't interact with that. So we are happy about that. And if it solves constipation and LDL, we're more than happy.
Thank you. Thank you, Vishwa. Okay, Sujit, coming to you from the nephrology perspective, we have so much interactions also there. Which is the most preferred or safest drug as per you or your practice in nephrology? People have constipation and
Yes,
CKD or AKI.
CKD population there, most of the patients are chronically constipated. We suggest them to go for fluid restriction. So the almost 80 to 90% of patients have the constipation. We usually prefer initially the high fiber diet and laxatives. That is the usual. And problem is with that drug says tolerance. After sometimes there will be no response with that. We have to change these medications. With the BixiBat, I want to add there is some interaction with cevilamer, which we use as a phosphate binder, which also acts to ileal region only by binding. So usually we tell most of the patients for phosphate binders to be taken with the food. So that's the concern which I have regarding this thing. Even though it's not safer and it's not removed through dialysis, that is the only interaction which I wanted to tell.
Okay, thank you. Thank you. Okay, to Nayantara,
Yes, sir.
endocrinologist. Diabetes and constipation often go hand in hand, especially uncontrolled diabetes, elderly patients. Same issues come there also. So what's your preferred suggestions for such patients who have diabetes and constipation?
So when it comes to diabetes and constipation, my first thing would be to stabilize the sugar, sir. When the sugars are above 270, we all know that the gut takes a hit. We know that hypoglycemia increases the gut motility and hyperglycemia decreases the gut motility. And especially when it is above 270, it more so. So my first thing will be to get the sugars down. And meanwhile, while I'm doing this, I would like to actually start on the usual thing that we usually start on is actually lactulose, even though the syrup is a little sweet, like how Anuruddha sir has rightly mentioned. That every patient who I start on lactose will come and ask me, ma'am, this is sweet, want it to increase my sugar? Then I'll have to tell them that it's not sugar. The sugar doesn't go up, but it's not, it's not absorbed inside. So that is one thing that I usually start on. And when they do respond to that, so sometimes when they're having diabetic gastroparesis, that is when I give them domperidone. For that also they do usually well. And the usual thing of increasing fiber and everything acts in their postprandial sugar control as well. So that way we go in that level as well. And the other thing is, the newer issues that I'm facing with diabetes and constipation is when I'm giving them GLPs. When I'm giving GLP-1 agonist therapy, I'm facing a lot of constipation in those patients. And Bixibat, when I was going through the articles, it was very refreshing to me that it actually has an incretin effect also, because the bile acids are coming down, so the incretins are going up. So it's a win-win situation for me, wherein the constipation is also relieved and the incretin that I'm giving is working better for this patient. So in that way, yes. And in from diabetic point of view, it enhances the DPP4 and also the incretins from the naturally itself, and also when I'm giving it as a therapy. So Elopixibad looks like a promising therapy to me, and thank you for Anirudhi sir and you to enlighten me that this drug exists and we can use this in my practice. So yeah.
Okay. Yeah, that's interesting. In fact, we are also facing challenges with this GLP-1 analogs.
Yeah.
When these patients come for endoscopy, they're fasting. Normally, 6 hours fasting is good enough.
No, on these patients, it's a little more.
They take 10 hours, 12 hours, and even then the stomach has food inside, and so does the colon. It doesn't get prepared easily. So if you're not aware of that, they're taking these medicines. Sometimes they have repeat colonoscopies, endoscopies, and then later the mystery gets solved.
Yeah.
Maybe get used to it because some of them hide and take it.
Yeah, yeah. Yes, very true. Very true. Agreed. Yeah.
Anything else anybody would like to add as a comment or a question to pose to Anirudh or anybody else? Anirudh, where would you place this drug now? There are so many options available to everybody now for treating constipation. Would this be a first line therapy, second line therapy, or a backup therapy for when everything else fails, or add on to others? What is your plan?
Interesting aspect that all of us start with fibers generally. But when I looked at the literature and also discussed with Dr. Satish Rao, who is considered to be father of constipation, he told that Indian patients are already replete with fibers. So this all fiber concept came when it was approved in America, and their fiber intake is very poor, like 2 gram, 3 gram, something like that. So we have to escalate the fiber intake. But in Indian patients, already they are replete with fiber. So if we increase it too much, it will cause bloating, and a lot of dyspeptic symptoms will creep in. And also fiber has a limitation that in severe polypharmacy patients and also severe constipation, it won't work. So my thing is that we can start right away with all these new agents also, if they are not on polypharmacy. But I would start something like a stimulant laxative, something like lactitol, not Dufalac or the lactulose plain. I'll plainly start lactitol sometimes, or fibers if the patient is not taking adequate fiber intake, and then add on to all these drugs. In some patients, however, I am starting with BixiBat as a standalone agent also, and it is giving good relief. The only problem or observation what I have noted is that our patients don't mind taking powders than tablets for constipation. So maybe there is a significant cultural impact on us that they are used to taking some Ayurvedic churnas, which are powders, and they don't like to take tablets for constipation. However, the thing is improving, and if we counsel them that it has got zero absorption, probably they'll be able to take it for a long time. So you can use it as a standalone agent or a first line agent also, or you can add after you have used the first line therapy, whatever you feel is right.
And how long? I
So
know
the
4-year data is there, but sometimes we have to give them just a
constipation is a
lifelong.
lifelong disease, and when we are counseling patients, we have to counsel them right. So some of them who are actually taking drugs and they are having constipation because of that, in that part it's okay. But we in our clinical practice rarely see any patient who improves after some time. So we have to be counseling them right at the onset that, like, you are wearing your specs, I would like you to use your specs and constipation is till the same time, till the time you are improving. So that means you are never improving, and you have to continue as per your requirements and titrate it to minimum possible dose if possible.
Okay. Okay. So I hope you didn't mean that you go wear specs and go to toilet, right? That's an analogy that you're giving, right? It also depends on how person takes it. We have had situations where you have to read the mind of the person. Natural intelligence is not so natural, actually. I have to explain to the attendant. Okay. Now coming to the safety profile, we heard that yes, in patients with Parkinson's and extrapyramidal symptoms, this has to be used cautiously. Anything else in your practice or experience you've had issues? Electrode imbalance, yes.
Sir, like the follow-up data, what is available probably with us also is maybe around 4 to 5 months somewhere down the line. Not significantly, I have not seen any patient coming back to us. However, I mean, extensively we have not monitored them. So probably Sujit and Dr. Bhishma and Dr. Nayantara might be requiring some monitoring when they see these patients. We see them quite just for constipation referral. So far, I have not seen any electrolyte disturbance, but diarrhea definitely. I have seen some patients getting spontaneous bowel movement within 30 minutes also after taking this meal, which is quite problematic because when they are leaving for office and if they take that drug and they are having a very fast bowel movement, that's a problem for them. So this is the only additional information which I would like to share, that some of them patients are having very quick bowel movement, which may be interfering with their daily uh, quality of life. Apart from that, no significant event so far.
So they have rapid gastrocolic reflux and they actually don't need it, right? They're already having more frequent motions.
No, so they are constipated, but some of them after starting the drug had a very rapid bowel movement. I'm not sure why, what is the mechanism. These patients do not have increased gastrocolic reflux. All of them are constipated patients only.
So these are IBS patients with constipation or pure idiopathic constipation?
Not analyzed so far, but constipation mostly, functional constipation, not the pain predominant constipation.
Okay.
Yes.
Okay. So as we come to the end of the interactions, anything else which we have missed out? Sujit looks very tense. Huh? Why?
Anything, sir.
So, one small query. So
Yes,
does it work same way in the long run? Like day one, does it work? After 2 years, 3 years, does it have any decrease in the effect? So now generally I start with Duflag, then Duflag plus, Cremafin plus, and then say that this is also not working. And generally these patients get used to all this, right? This drug has this similar problem?
So very important question.
So the question is there a tachyphylaxis with these medicines?
Very important question. I missed that slide actually. So I wanted to make it crisp to discuss and allow a lot of time for discussion. So this drug has zero tolerance. In the long-term follow-up of 4.5 years also, there was zero tolerance and there is no tachyphylaxis with this drug.
Okay, so that's important, yeah. So there is not much of interaction, not much of tachyphylaxis. It's fairly safe drug, can be taken for long time. So net, it looks quite good. Only thing we have to use it now in our own practice in different specialities and see how it resolves their problem. Because most patients are fixated on the bowel. Even if they have MI, they will still be worried about their constipation. They haven't passed motions. Vishwa, you face this problem? You're muted, Bhishma. So I know you said, Bhishma, you're muted.
Yes, sir.
Can
Yeah.
you? So you said that the patients sometimes the heart attack gets precipitated or LVF gets precipitated because of constipation pressure that they apply in the colon or rectum. But other way around, they're fixated. Some of the patients are so much fixated that they feel that the cardiology problem is not so important. They may have an ejection fraction of 15, but it's the colon which is taking their life away.
Yeah, we have a lot of patients like that. So they are hell bent on treating the constipation. So they rather want to pass motion than
Yeah.
so you know that it's a major issue in elderly and all these frail patients. So they're hell bent on passing stools every day. So every time they come to my OP, one of the last question is constipation. So doc, is it because of your drugs? Can you help me? Is what I get every time. So I think it's too good to be true. This drug, I think.
That's true. Yeah, yes, everything. Look, every new drug which comes with a bang. Yeah, but we have to kind of the pendulum will keep swinging in one way to other, and then it'll probably settle down in one middle path. So hopefully, with our accumulated experience, as Amrit was saying, over a period of next months or years, we may be finding it. This molecule may find some place somewhere in the treatment of constipation in patients who have more than one problem.
Yes.
Hello? Yeah.
Yes.
Anything else from anybody else before we wind up? I think it's already, we can't discuss constipation on the at such late times.
So, Dr. Anirudh, I have a question. So,
Yes.
sir, in your clinical practice, in what percentage of patients there was a need of increasing the dose to 15 mg in your practice?
Maybe less than 10%.
Okay.
Yes. So
Sir, in
majority of our
Parkinson's
patients
patient,
are improving on 10.
okay.
Yeah. So or also like de-escalation was also rarely required. So I'm using with the 10 and rarely I need to de-escalate or escalate otherwise as well. Yeah.
So, what is the your comment on using this BixiBat in chronic liver disease patient in your practice?
So the concern regarding CLD is that actually a lot of our hepatologists are using for refractory itching, which is commonly seen pruritus in primary biliary cholangitis and also some patients who are having CLD with itching. So interestingly, the bile acid pool is lower because of cirrhotic liver, but still they have itching, and some of them responded very well to BixiBat, like I discussed with my colleagues Dr. Anand Kulkarni and Dr. Shantan. So interestingly, we don't have any data all over the world, and I was requesting Dr. Reddy's to help us design a trial for CLD patients, whether it is safe, because mechanistically and pharmacokinetic wise, it was looking promising. But the majority of the data comes from lactulose because it has got other effects on cirrhotic patients, like altering the microbiome, also like having secondary pleiotropic effects apart from improving the constipation. So we must do the same and accumulate more evidence regarding ilopexibat as well. So I think Dr. Reddy should take it up in India as well as globally, that there is not much of data in CLD patients, and we can go ahead and conduct a trial.
So Linda, you got the hint, and I'll push too.
Correct. Yes.
So I think not only CLD,
Yes,
I
sir.
think another even in cholestatic liver disease, for example, PSC and as I said PBC, or even prolonged viral hepatitis when they have itching as the predominant symptom. At that point, I think instead of using UDCA, which is a common drug that we use, I think this may add value,
Yes.
especially if you also want to relieve constipation in those patients. So itching plus constipation,
Yes.
it's two birds into with one stone.
It was primarily made for itching only, sir. And
Yeah. So it's coming back the full circle now.
And the congener is coming, another drug which is the potentially better version of ilopexibat, which does not cause diarrhea and it improves itching. So it is the same kind of drug working through the same channel, but it has less constipation.
Okay.
Yes, sir. But currently that's not available with us. So ilopexibat becomes an important option in that category.
Okay, thank you. Thank you very much, everybody. I think, Linda, we can wind up. Alpesh, if you agree, I think this was a nice interaction
sir.
that we had with cross specialities, experts in their fields who have several other experiences, and constipation being a common binding factor of all these patients. Um, we learned a few things from each other, and hopefully we may be able to solve, if not all, some of the problems of these patients. Thank you. With that, I think we can wind up here. Alpesh, you can have the last
Yeah.
word.
Yeah. So, sir, I think first of all, I would like to thank you all the our participants for today's cross-functional webinar, and special thanks to Dr. Sandeep Laktakia sir for chairing and moderating the session, and Dr. Anirudh sir for I think a fantastic presentation. I think which has clarified the doubt of everyone. And thank you very much, Dr. Bhishma, Dr. Nayantara, and Dr. Sujit for being part as a panelist, and I think adding a lot of value, because this is just a second program what we are doing on this cross specialty webinar, because we want that this is a new molecule and it has, because of its pleiotropic actions, I think it can be helpful in all the cross specialty. So thank you very much once again to everyone for this fantastic work. Thank you. Thank you.
Bye-bye. Bye. Good night.
Thank you
Good
very
night.
much.